Many have dreams to be a medical professional. When choosing an institution for medical school, a lot of things matter. The quality of the academic and clinical programs, as well as the clinical experience. At Unimas, we offer that and more. A supportive culture, a vibrant community, diverse student and patient population, all set against the backdrop of Kuching and Kota Samarhan.
The culture here is welcoming. It is a big family. Everyone wants the next person to succeed together. We want our students to reflect back to the society and the community today. As a community-driven university, we believe that immersing themselves and ourselves in the diversity, it creates better innovation and greater creative achievement.
In Unimas, there's not a culture of a competition here, but a great environment is what we all strive for.
Everyone is committed to create a great environment to become a great doctor in the future.
Our patient population in Malaysia is remarkably diverse. Different languages and dialects will be something that we face every day once we become a doctor. So, getting to know this and learn it now make us to be more appreciate and respect. It just set us up to become a better doctor for the future.
From the beginning of the program, 25 years ago, we have adopted a spiral curriculum. As the students advance forward into their years of clinical study, we connect everything back to underlying basic biological sciences. We connect and revisit every aspect of human health, from emotions to diseases, back to its basic biological sciences.
We are introduced to clinical setting early in our curriculum. The exposure gets more as we advance through the year. It was very daunting at first, as a first-year student, to step into hospital and seeing patients. But at the same time, it's really an exciting experience.
We are committed to excel in nursing education, research, and practice. It views health as a complex and dynamic, and the client as a holistic individual. Students in this program learn in an environment that stimulates intellectual. Many have dreams to be a medical professional. When choosing an Many have dreams to be a medical professional. When choosing an institution for medical school, a lot of things matter. The quality of the academic and clinical programs, as well as the clinical experience. At Unimas, we offer that and more. A supportive culture, a vibrant community, diverse student and patient population, all set against the backdrop of Kuching and Kota Samarhan.
The culture here is welcoming. It is a big family. Everyone wants the next person to succeed together. We want our students to reflect back to the society and the community today. As a community-driven university, we believe that immersing themselves and ourselves in the diversity, it creates better innovation and greater creative achievement.
In Unimas, there's not a culture of a competition here, but a great environment is what we all strive for.
Everyone is committed to create a great environment to become a great doctor in the future.
Our patient population in Malaysia is remarkably diverse. Different languages and dialects will be something that we face every day once we become a doctor. So, getting to know this and learn it now make us to be more appreciate and respect. It just set us up to become a better doctor for the future.
From the beginning of the program, 25 years ago, we have adopted spiral curriculum. As the students advance forward into their years of clinical study, we connect everything back to underlying basic biological sciences. We connect and revisit every aspect of human health, from emotions to diseases, back to its basic biological sciences.
We are introduced to clinical setting early in our curriculum. The exposure gets more as we advance through the year. It was very daunting at first, as a first-year student to step into hospital and seeing patients. But at the same time, it's really an exciting experience.
We are committed to excel in nursing education, research, and practice. It views health as a complex and dynamic, and the client as a holistic individual. Students in this program learn in an environment that stimulates intellectual inquiry and creativity, which encourages them to be problem solvers and lifelong learners.
Here, we learn how to care, to serve, and to help. We went from zero to hero.
I really cannot pick a better place to learn and become a greatness. This is a place that belongs to my heart throughout my journey.
Come do research with us.
Come and join us at UNIMAS and realize your dreams.
Health Talk Series 2022. I'm Dr. Sim Hui Ling, your moderator for today's session. I'm from the Pediatric Department of Faculty of Medicine and Health Sciences, UNIMAS. Before we begin, I would like to thank the organizing committee for organizing this talk, which I hope everyone will benefit from this talk here, especially those who have young babies at home or those who are going to have babies in the future. Please take note of some housekeeping announcement. All participants are requested to type your questions in the chat box, and we will answer them at the end of the talk during the Q&A session. For the CPD points for medical staffs, QR code will be shown at the end of the talk. You can scan the QR code to get your CPD point. For e-certificate, please fill in the Google attendance form. The link will be provided at the end of the talk in the chat box. The topic for today is, Doctor, why is my baby yellow? When a newborn baby is yellow, we refer to this condition as neonatal jaundice. So, with us here today, we are very privileged to have two very experienced pediatricians. Let me introduce them to you now. The first speaker will be Professor Dr. Mohammed Aminuddin, who is currently the head of Department of Pediatric in Faculty of Medicine and Health Sciences, UNIMAS. He has been serving UNIMAS for the past 15 years. He is also a consultant pediatrician in Sarawak General Hospital. Let us welcome Prof. Dr. Aminuddin.
Assalamualaikum and good morning to all the audience. Welcome to our talk.
For the second speaker, we have here with us Dr. Tan Sulin, who is also a lecturer in the Pediatric Department of Faculty of Medicine and Health Sciences in UNIMAS. She's also a practicing pediatrician in Sarawak General Hospital. Welcome, Dr. Tan.
Good morning, Sim and everyone.
Without further ado, we will now invite Prof. Aminuddin to tell us what is jaundice.
Okay, thank you, Dr. Sim. Assalamualaikum and good morning to all the audience there. All right. Well, we are talking about why is my baby yellow, or the topic we call this as neonatal jaundice. All right. Before I proceed further, let me explain to you the meaning of this word. Neonatal means in medical means baby less than 28 days and below. Okay, newborn baby. Jaundice basically means discoloration of the skin and eyes. All right. So if this happen in adult or bigger child, then usually they indicate there's some disease or illness underlying. But in newborn baby, this is part of a normal process. All right. Why is it so? Okay. Maybe to make things clearer, look at this nice slide here. Okay, diagram here. What happen in newborn baby is they have a lot of red blood cell which going to be converted into adult red blood cell. So this red blood cell will go what we call hemolysis or breakdown, and breakdown of this red blood cell will then cause release heme, which is a iron containing protein. This heme will be subsequently will be undergo some process. Don't worry about the technicality of this diagram. Just to make it simple, the heme, which is an iron containing compound, will be break down by some enzyme in the body, and this will release some at the end of it called bilirubin. This bilirubin is the one that causes us to become yellow. Okay, and you can see in this diagram, if the bilirubin is free bilirubin, it can, and very high, it can be toxic to the brain, which we'll talk about it in detail later. All right, and basically the bilirubin will be taken by the liver, processed and excreted in the gut and the urine as well. So basically this is what we call neonatal jaundice lah. They are becoming yellow because of this increase in bilirubin. Okay.
All right, thank you, Prof. Amin. I think majority of you will agree with me that most of the newborns will become jaundice. Is this something normal, or is this something that we should be concerned and worried about? Now we'll have Dr. Tan to explain to us about this.
Yeah, so jaundice, yes, it can be a normal phenomenon. Okay, so jaundice in babies actually a lot of times is just a normal transitional phenomenon. Actually, all babies will have a transient rise in bilirubin levels, okay, but not all will become visibly jaundice. Okay, if your baby is a term baby, cukup bulan lah, I say, so about 60% will turn jaundice. But in the preterm baby or cukup bulan, up to 80% will become visibly jaundice. Okay, so why does this bilirubin accumulate? Okay, it's because of there's an increased bilirubin production, and at the same time there's also poor bilirubin clearance. Okay, so naturally in the newborns, they have a relatively full red blood cell count, and at the same time their red blood cell also have a shorter lifespan. So all these cause more red blood cell to break down, okay, and therefore cause an increase of bilirubin production. Okay, and then at the same time, the newborn's liver and gut is still quite immature at that time. Okay, so they cannot cope to clear this. So therefore, the bilirubin accumulates, and therefore it's common, okay, for newborn babies to become jaundice. Okay, in fact, in most babies, actually, the jaundice is physiological. Okay, so because jaundice is so common, so it's good that actually there's a method to detect this jaundice or assess the severity of jaundice using a visual assessment. Okay, so this visual assessment needs to be done under natural daylight, natural light. Okay, visual assessment means that we just use our eyes to see, we guna mata kasar. So so how it is done, okay, is by applying pressure with one finger on the baby's skin, usually at the forehead or the chest, okay, and then remove the finger. Then you observe the skin that has been pressed. Okay, so if the skin looks yellow, indicates that baby, if it appears whitish or pinkish, then not jaundice lah. Okay, so this visual assessment actually is we use the Kramer's rule. Kramer's rule is based on the fact that the jaundice will progress from head to toe. Okay, as you can see in this picture here. So first, it will be noticeable over the face and head region at level 1. Okay, then it will progress downwards. Okay, like level 2 over the chest here, level 3 over the tummy area, and then 4, okay, over the arms and the legs, and finally to level 5 over the palms and soles. Okay, so if you see the extent of jaundice is only about at level 1, if you check with a blood test, as we will discuss later, blood test, I can expect the bilirubin level to be around 5 milligram per deciliter. Okay, but if it's already down to the level 5, so the bilirubin will be very high, actually close to 20 milligram per deciliter. So actually this value is high and dangerous. So if at any time you see your baby's jaundice is extending beyond the chest, lower down, you quickly need to seek treatment and get your bilirubin checked. Okay, so what we need to remember that this visual assessment is only used like an estimation and a guide to the severity of jaundice. Okay, so it need to be confirmed with a blood test. And it also, once the baby is already receiving treatment for the jaundice, then you cannot use this visual assessment to assess the severity of jaundice anymore.
Thank you, Dr. Tan. It is good to learn that we can actually assess the jaundice level by visual assessment, a rough estimation. So from your talk also, we know that jaundice can actually be something normal and also transient. It's quite reassuring to the new parents so that they are not so worried when they are told by the doctors that their babies are jaundice. So we'll now learn more about this normal jaundice, or what we call physiological jaundice, from Prof. Amin.
Okay, all right, thank you. All right, so when you say physiological in medical term, it means it's normal. Normal physiology is what normally happens in normal physiological process is what's normal to your body lah. All right. On the other hand, when you say pathological, means which consists of disease causing condition. All right. As we mentioned before, as Dr. Tan mentioned just now, most of this is physiological, and you know why is it. Before I proceed further, probably I should want to elaborate a little bit on how we measure this so-called bilirubin level. It is usually mentioned in terms of milligram per deciliter. I think all the mothers, they very used to the value that when you go for checking blood for bilirubin, they say 10, my SB is 10, 15, 12 kan? So this is the unit called is milligram, right? So that indicate how high is the bilirubin level, serum bilirubin or SB in our body. For adult is and normal child is less than 1 only, less than 1 milligram per deciliter, right? Whereas in the hospital, we also have another unit, which, for example, is called micromole per liter, which we equivalent to 10 milligram is actually 170. They use slightly different unit, but no need to worry about this. All right. For what is more practical for us outside there is the milligram, 1, 5, 10, and so on. Okay. So when we say physiological jaundice, first thing that you have to remember, you not see the jaundice on the first day of life, meaning that the first 24 hours of life, the baby should not be jaundice, right? The jaundice is visible to our eye, trained eye, or even to maybe normal people, is actually the bilirubin is 5 milligram per deciliter. All right, so the baby can have increased bilirubin, but still not visibly jaundice. All right, so if the first day of life, within 24 hours of born, the baby looks jaundice, that's something you need to bring to hospital and go to clinic and check, because I will talk about the many reasons for that. All right, so don't think, oh, this is I just attended a health talk, and this but NNJ can be physiological. All right, so in this case, it is not physiological. So physiological jaundice or normal jaundice is usually happen, is visibly jaundice from day 2, day 3 onward. Okay, and then it slowly progress, and by 5th day, usually already 5th to 7th day, they already reach a plateau, means a steady level. All right, as you can see in this diagram here. All right. And then after that, it will come down. In the East Asian population, like in our country here, it tends to be a higher peak and also come down a little bit less compared to all this Western population. All right. So, for example, in this slide, you can see the for term baby, the peak is also lower. Preterm babies tend to be higher and a bit later. All right. So simple. So the SB usually peak around 5 to 7 day of life, around 8 to 12. Okay, for everyone. Okay, and then it will by 10 days to 40. By 10 days usually come down. 10 to 14 days. Okay, should be disappear. All right. So anything beyond 14 days already usually not physical jaundice, even though in some cases it can be exaggerated lah. All right. So if you need to see a baby have jaundice in the first 24 hours, please go. and see doctor. After that, still you need to see, because as mentioned just now, visual assessment may not be accurate. How do you know how high is it, isn't it? So you need to bring to clinic kesehatan or any specialist clinic or maternity home there and check the bilirubin. We will talk about this later on. Okay, so in physiological jaundice, usually the bilirubin not very high, and they will come down. If you don't do anything, also it will come down most of the time. They may not even need any treatment. Okay, however, they need to be seen by nurses and doctor to make sure there is no other thing, other illness behind it. Right? As a rule, if the baby is unwell, apart from the first 24 hours, if the baby doesn't look well, not feeding well, having fever, or not well, then it may not be physiological, because there might be underlying cause. We can talk about this later on in detail, as well as the high bilirubin itself can cause the child to become ill. Because if you see the first slide that I show you, the unbound bilirubin, serum free bilirubin can cross the blood-brain barrier and cause brain damage. And this can, but this is only in severe cases, all right? Don't worry, the normal physiological jaundice is usually not a problem, okay? So if, like Dr. Tan just now mentioned, this so-called Kramer's rule, isn't it? If you see the palm and soles become yellow, for sure that is a very high level, 18, usually around 18 and more. So you need to go to hospital. Okay, so this Kramer rule, even for, I think many mothers bring their baby to hospital and they notice the child is very yellow. So if you press on the palm and soles is yellow, or the arms, lower arm, lower legs is yellow, you need immediate attention. Okay, okay, yeah, that's about it for the time being.
We often heard from the nurses and doctors in the clinics checking the babies for jaundice that your baby is at high risk of jaundice. So there are actually some risk factors that may lead to severe jaundice in newborns. What are the risk factors that are associated with severe neonatal jaundice?
Yeah, there are many risk factors that can exacerbate the normal jaundice in baby and make the jaundice severe. So it's very important for us to identify these factors and so that we are prepared to manage. Okay, so listed here are some of the major risk factors. For example, if having a different blood group from the mother, let's say the mother is a blood group O, but the baby is not blood group O. Okay, as a prof will explain a bit more later. Okay, other than that, there are some genetic causes that cause our red blood cell to break down more easily. And one of them is such a condition called G6PD deficiency. Okay, so because it's quite common in our population, so I'll talk about that a bit later also after this. Okay, and then an ill baby or a baby with infection also is a risk factor to get a more severe jaundice. Besides that, suboptimal breastfeeding in an exclusively breastfed baby. Okay, so will also increase the risk for that baby to get a more severe jaundice. Sometimes if there's a difficult delivery, if the baby sustains some bruising or mild tissue injuries, okay, so the accumulation of blood in these injuries can also break down and also contribute to the increased bilirubin production. Therefore, it's a risk factor for jaundice. Okay, so other risk factors include prematurity, having a low birth weight, or a positive family history of severe jaundice in a sibling who actually required treatment for that. Okay, so these are risk factors that's important for us to identify.
Okay, so it's actually very important for us to note the risk factors that may potentially cause severe neonatal jaundice. So I'm sure mothers with whoever with blood group O or rhesus negative, you must be curious now. How this blood group O and rhesus negative causes severe jaundice?
Okay, all right. I hope you are curious but not scared lah. Right? There's no reason to be scared. Okay, so first let me talk about this blood group. How do we determine the blood group? Right? There are many types of blood group, but the major blood group is so-called the ABO rhesus. Right? So we have blood group A, B, AB, and O. Right? And rhesus means positive or negative. Right? So what determines this blood group? So I would like to explain in a very simple term so that you understand what I'm going to say further. Right. So when you say blood group A, there's in the red blood cell of the person, you have this something called A antigen. Antigen is a protein or sugar attached, a molecule attached to the red cell. So if they have A antigen, they are blood group A. If they have B antigen, they are blood group B, right? And or they don't have this, right? And at the same time, in their blood, okay, which is called serum, right? Blood cell is another thing. That blood is another thing. Like in the blood, we have red blood cell, we have white blood cell, we have platelet, cell darah beku, right? So in the blood itself, they also have antibody against the should be against the antigen that the person don't have. For example, if this fella have a blood group A red cell, he have antigen A in the red cell, so he have anti-B. So he cannot have anti-A. If you have anti-A, the red cell will break. All right. So if B, they can have anti-A. All right. And O, they have both anti-A, anti-B. But AB doesn't have both antibody. So two things here. One is antigen, one is antibody. All right. I think I make it simple here. Sometimes we need to know this to understand. All right. Otherwise, there's no reason to give a health talk. Okay. All right. So then what happened then? When a mother is O, so as you mentioned just now, okay, and the baby is say A, right? So mother have this antibody, it can be anti-A, anti-B, all right? So during the pregnancy, this antibody usually can cross the placenta, I mean the womb, okay? Rahim lah, okay? So cross and get into the baby, and this antibody will cause hemolysis or breakdown of the red blood cell. Not the normal breakdown that we talk about just now. It's actually more exaggerated, more breakdown. So what happened then? All right, and because of this, the red blood cell will come down in amount, so they can become pale and anemic, we call it. And as we know, that red cell breakdown causes jaundice. All right, so the jaundice can be high. So typically, this is called what we call ABO incompatibility, and they become jaundice usually first day of life. There are other causes of hemolysis or red cell breakdown which can cause, but ABO incompatibility is one. But the good thing is that this ABO incompatibility is not as severe as something we call rhesus incompatibility. All right, rhesus incompatibility is the mother is rhesus negative. All right, the baby is rhesus positive. That can usually cause more severe red cell breakdown. But fortunately, the rhesus negative is very uncommon in our population. All right? So what do we need to be aware? But also, even though AB incompatibility can happen, but it is not also as severe. Or most of the baby born to them, mother be with O, they do not have very severe hemolysis. Maybe there's mild hemolysis and so on, but usually they are not that severe. And some of them can be bad, but the proportion is still small compared to rhesus. So what should we do now here? So if the mother is O, then probably you need to be more careful with your baby when born, when the baby is jaundice, especially first 24 hours, you have to be aware and bring to hospital. And that's number one, okay? Number two, of course, when admitted to the hospital, we will also monitor more closely as well. And if necessary, we may do some other blood tests to make sure is there any really ABO incompatibility is causing this jaundice, or is it just a physiological jaundice? All right. So take home at the end of the message here is, if somebody with blood group O, and if the baby is A or B, there is an increased risk of more red cell breakdown and more severe jaundice. Okay, but I hope this doesn't make you worry so much, because we have so many patients with O, and we do see them have jaundice, but not many of them really become very severe. Partly also because they are admitted, and we also treat them very early. All right.
Thank you, Prof. Amin, for your explanation. I'm sure it will be very reassuring to those mothers with blood group O now. Okay, so next we will come to this G6PD deficiency. I'm sure mothers who has babies with G6PD deficiency, you may have some very not so pleasant experience when you are told by the doctors that your baby is diagnosed with is detected with G6PD deficient, and we need to keep your babies for 5 days in the hospital for observation. So actually, what is this G6PD deficiency?
So G6PD deficiency is a genetic disorder. Genetic meaning that it can be passed down from the parent to the child. Okay, and most commonly it affects the males, boys. Okay, it is more common in certain populations, so like in Asian population. That's why we would like to highlight this condition. Okay, so actually G6PD is a chemical or an enzyme that can be found in our red blood cells that is important to maintain the structure and stability of the red cell. Okay, so what happens when a patient with who is deficient in this G6PD enzyme, so their red cells can easily break down, particularly if they're triggered by certain agents. Okay, so when the red cells break down, then there will be increase in bilirubin production, and therefore the jaundice can be severe, especially and can be dangerous in the newborns, in the neonates. Okay, so so that's why if your baby is diagnosed with G6PD, then you will advise them to avoid certain triggers. So what are some of the triggers? Okay, can be food such as fava beans, also known as kacang parang. Okay, also can be due to chemicals like mothballs, or what we call ubat gegat that we keep in the cupboard for your clothing to prevent mold. Okay, it can also be triggered by certain drugs and medications like antibiotics. So if you have G6PD deficiency, when the doctor prescribes you medication, you must always inform them that you have G6PD deficiency, so they do not prescribe any drugs that may cause your red blood cells to break down easily. And of course, one of the common trigger is actually infections, but like viral infections, but of course, it's not easy to always avoid infections. Okay, so because it's a relatively common condition here, so in Malaysia, we have a newborn screening program to detect this G6PD deficiency. Okay, so all the babies born here, they will be routinely screened for G6PD through the cord blood, the darah dari tali pusat will be checked for G6PD, and your status will usually be known within the first 1 to 2 days of life. Okay, so if your baby noted to be deficient, then yeah, as Dr. Sim said, then you need to tahan ward that will be admitted for the next 4 to 5 days for closer monitoring of the jaundice, because as you know, it can be severe jaundice if your baby is G6PD deficient.
Yeah. Okay, thank you, Dr. Tan, for enlightening us on this G6PD deficiency. So, as we are all aware of, ill babies are also at a higher risk of developing severe jaundice. How does that happen, Prof. Amin?
So one of the reason that we can have jaundice is what we call sepsis, infection in the neonate. Okay, as you know, infection means you have kuman line, usually bacteria or virus, etc. All right. So as mentioned before, if the baby is jaundice, we know this could be physiological, but there are also many other causes. As mentioned, ABO incompatibility, G6PD. One of the important cause for jaundice is actually sepsis or infection, or we call it neonatal sepsis. All right. When a baby have infection, they can be very presentation how they have symptom can be very so-called non-specific in medical term. Non-specific mean like if an adult have infection, what usually have? You have fever, kan? You have cough, and so on, kan? You feel unwell, body ache, but baby cannot complain also lah. That's one thing. So non-specific mean they may just have poor feeding, they refuse to feed, poor sucking, they could be just vomiting, a few episodes of vomiting, or the tummy may be a bit distended, all right, or they may look off color and so on. But one of the important symptoms, amazingly, is jaundice itself, right? So in a neonatal sepsis, the baby may not appear to be any other symptom but jaundice. So this is very tricky, right? So we may think this is just this is not normal jaundice or physiological jaundice, but the child is actually septic, all right? So so the rule here is if the child, jaundice can be the only symptom. as well. And so that's why if the child have a very high level of serum bilirubin, or the jaundice happen very early, or the child doesn't look well for any other reason, you need to consider sepsis as a cause of jaundice. And this stress the importance of bringing the baby to hospital to be assessed, not just stay at home and use our own treatment, or even home treatment for phototherapy maybe. All right, so sometimes can be a bit risky lah. All right, it depends on the condition of the child. Okay, so one of the important causes is neonatal sepsis. All right, and how does the baby get sepsis? How does the baby get infection? Usually this is through the maternal birth tract. When they are born, exposure to the fluid secretion, sometimes prolonged leaking of liqua, we call this, or maternal mothers have fever during or urinary tract infection, or sometimes we don't know. Some maybe do carry something we call GBS, group B streptococcus, and so on, in some kind of bacteria. So they may be turned septic lah. So we have to be aware of sepsis as well as possible cause of jaundice. But for you, don't need to worry. As long as the baby is jaundice and you just bring to hospital, the doctor will decide and will examine the baby and decide whether this need to be admitted and so on.
Yeah, I agree with you. If you notice any symptoms, or you think your baby look different from the usual self, please immediately bring your baby for a check in the hospital.
And for this jaundice baby, and once they are neonatal sepsis, they have to be admitted and taken some more blood and start antibiotics, right? And the important thing about neonatal sepsis, you have to treat them early and with a proper antibiotic. If they are treated early, usually they respond, even though the immune system is not that good, but they respond well and they recover. But if sepsis is delayed, and unfortunately, it can be very difficult to treat.
Yeah, so it is important to seek treatment early. Okay, all right. So many, I think, will be surprised to see that breastfeeding is also mentioned as one of the risk factors during the slides for risk factors for severe jaundice. So does that mean we should stop breastfeeding or discourage breastfeeding? Do you agree with this, Dr. Tan?
Yeah, no, definitely not lah. So breastfeeding should not be stopped just because the baby is jaundice lah. Okay. So breast milk is actually the best nutrition for our newborn babies. In fact, the World Health Organization (WHO) recommends mothers worldwide, to exclusively breastfeed their babies for the first 6 months of their life to achieve optimal growth, development, and health. Okay. So yeah, breast milk is definitely best for babies. So actually, why does breastfeeding jaundice happen? Okay, so this happens is actually because the breastfeeding is inadequate, or the suboptimal breastfeeding. Baby is not getting enough milk. Okay, this may be because of the lactation failure. Mothers are not producing enough milk, and so this leads to dehydration, and baby can have a significant weight loss. So this is the reason that causes the baby to develop jaundice. Okay, so if the breastfeeding is actually successful and going well, baby is gaining weight, actually there shouldn't be a cause to cause jaundice. Okay, so the solution for breastfeeding jaundice is actually not to stop the breastfeeding, because there are so many more benefits of breastfeeding to both the mother and the baby. So for instance, for the baby, it can protect against certain illnesses, obesity, asthma, and for the mother also, it also helps to reduce the risk for breast cancer, type 2 diabetes, mellitus, and so on. Okay, apart from the health benefits of breastfeeding, okay, it's also good for bonding between the mother and the baby. Okay, and it's also portable, readily available. You don't have to find the milk bottle, boil water, and so on. Okay, so it's very convenient. Okay, and you can also save money by giving breast milk. Okay, so there are many benefits of breastfeeding. Okay, so do not stop breastfeeding. Instead, we should provide education and lactation support to all our mothers. Okay, so how to improve the milk supply is by encouraging them to and frequently on demand. Okay, on demand. Okay, and then also you should encourage to room in mother and 24/7, day and night rooming in. But if at any time the baby needs to be separated from the mother, then we should teach the mothers how to express their breast milk, okay, in order to yeah. Members, we should also support our breastfeeding mothers by giving them encouragement. Okay, let them get enough rest, drink adequate fluids, and also maybe help around with the housework, with the baby care, so that there's enough rest and not too stressed during this breastfeeding time. So we do not breastfeeding just because of jaundice.
Yes, I totally agree with you, Dr. Tan. Okay. Breastfeeding is the best for the babies. It actually provides the perfect food for the baby. So we should always encourage and also support all mothers for breastfeeding, especially those with young babies. So breastfeeding should not be stopped. All right. So next, how do we know whether your baby is jaundice or not? Is there any check for it, or is there any test for it to see whether your baby is jaundice or not?
Okay, all right. As mentioned just now, we can always, the visual assessment will tell you the baby is jaundice, all right? So once they are jaundice to a certain level, especially more than the face, and we may do serum bilirubin or short forms SB lah. I think all the mothers are very familiar with this word SB, bukan special branch, serum bilirubin, SB, right? Okay, so SB. So kalau kita bawa klinik, go to clinic, and they will do the SB check. And usually how they take the blood, usually at the heel prick, because the heel is the most padded area there. So they have a small needle, prick at the heel, and then get the blood into a small glass tube. Okay, this is the commonest way to do lah. All right. Of course, some places they may do venous blood, but this is a bit more invasive. But there are certain conditions. Sometimes especially if you think the serum bilirubin from the heel prick is too high and so on, whether you repeat that one or sometimes they take a venous blood. But because sometimes it can be falsely high, very high, because if not properly taken, too much of squeezing the heel and so on. All right, that's a thing that don't need to worry about that. The doctors will handle that. We know when to suspect this thing, but the commonest and easiest we do is serum bilirubin lah. Okay, and based on this, the child will be either sent back home and come back for follow up, or they might be referred to hospital to be admitted lah. Right. I think you're all very familiar when you go to clinic and they do a SB check and then decide, okay, this level you go to hospital. If you ask me what level they have to be admitted, it depends on the age of the child. There's a graph that we see for this particular age. Anything above this, they may need some treatment. They have to be referred. All right. But if you talk about, generally speaking, about more than 4 days of life, 4 days onward is around 14, 15 that usually they get admitted lah. There's a general rule. Definitely 18, 20, this one memang sure kena admit. But for younger baby, maybe 12, right? It depends, right? So around usually more than 10 lah, okay? Except we're talking about premature baby. So serum bilirubin is the one that we have the main thing. And this actually measure something we call unconjugated bilirubin. Just now I did not touch about this. Actually the bilirubin two type. Unconjugated is the normal bilirubin that and also conjugated, right? So if the child admitted to the ward, and then if they suspect any other reason for the high SB, for example, I talk about ABO incompatibility just now, then especially if the SB is high, then the doctor may do some other blood test in the ward lah, like blood grouping of the mother blood group. Usually we know, and during the maternal for a health screening follow-up, we already know. So baby one will be checked. So they may send group cross-match if need for something we call any exchange transfusion if needed, or also Coombs test. Coombs test is something to see whether is there really, because not everybody with a blood group O, mother, baby A and B, this one definitely have hemolysis. No, maybe other pun may be very mild. So if it is significant, then we have to do something called Coombs antibody test. All right. And of course, as mentioned just now, G6PD tests can usually have been done. And sepsis, if needed, they may do some other tests to take the blood for culture and so on. All right. It depends on the condition of the child, but the basic test that we do is a serum bilirubin, and from there we will decide. And one more thing also in the clinic, sometimes pricking the baby is still painful, even though heel pick is also maybe painful to the baby. So we, if in some places they have this transcutaneous bilirubinometer. Transcutaneous means through the skin. So they put a small probe on here, or the chest, or in the body there, and this actually measures the spectrum of the light, and just put a probe like a ultrasound probe there, and then they can give you a reading. All right, this is called transcutaneous bilirubinometer, but this machine is quite expensive, around 20 plus K and so on, so not everybody have it. It is available in some of the clinic kesihatan in our Kuching here, maybe in Sarawak as well, and some private hospital or homes may have it, and also our general hospital, also in nursery we do have it lah. All right. So how do we use this? This one is more for a screening. Screening means we just okay, let me look at this baby. It looks jaundice, kan? So I want to know how high is it. So put there, or it tells you 10. Okay, so it's reassuring, it's not too high, so probably no need to take the blood. But this is not above certain level, it is not accurate, especially if the SB go more than 12, 15, it's already not so accurate, then they need to do a serum bilirubin level. Okay, so generally for screening purpose is quite good. All right, but our nurses is also very trained. The very senior nurses, their eyes are very good also. If studies have proven that actually they are also very good at detecting a serum bilirubin more than 15. This is not what I say, it's in the clinical practice guideline. All right, so they are also very high SB, can be easily detected by the very trained medical staff. For one reason, for example, if you see the lower leg and the hands, sole jaundice definitely is high lah. So why should you just rely on transcutaneous bilirubinometer? You need to take the blood and really find the value. In that case, maybe you query, if it's say your TCB say low, but you clinically is high, you better take the blood test. Okay, so these are some of the tests that we can do to find baby lah with jaundice and decide the further treatment.
Yeah. Thank you for your info. Okay, so if the baby is jaundice, how can the baby be treated? What are the available treatments?
Okay, so the mainstay treatment for neonatal jaundice is with light therapy, what we call phototherapy. Okay, but not all babies who are jaundice must have phototherapy lah. Okay, so the decision to start and stop phototherapy will depends on a few factors, which includes the baby's serum bilirubin levels, okay, their age, and also their risk factors. Okay, so it will be given only if indicated, and we will refer to the threshold graphs for treatment. Okay, so how is phototherapy done? Basically, we shine a special blue light. Now, this is a special blue light with a specific wavelength into the baby's skin. So baby's skin is fully exposed, okay, but the eyes need to be protected with eye pads to protect against damage to the eyes. Okay, so what happens is the bilirubin in the baby will absorb this blue light, and then it will be converted to harmless substances that can be subsequently be excreted by the baby through the stool and the urine. Okay, so phototherapy is the most common treatment for neonatal jaundice if the treatment is indicated. Okay, and in most cases, it's the only treatment that is required. Okay, phototherapy. And for phototherapy to be effective, it need to be given continuously lah. Okay, so it can only be stopped for breastfeeding or for some nursing care. Okay, it's generally very safe treatment, okay, but there may be some side effects which are only temporary, okay, such as skin rashes and some loose stools. So meaning once you stop the phototherapy, the skin rashes and loose stool also will disappear. Okay, but because the baby is fully exposed during this treatment, so sometimes they can get a bit overheated or even get cold. So that's why when babies are under phototherapy, they need to be closely monitored. We'll monitor the vital signs and the temperature for hourly to make sure none of these problems occur. Okay. So and clinical experience has shown that there are no long-term adverse effects of phototherapy. So it's a safe and will be given if needed.
Just now, Prof. Amin did mention something about exchange transfusion. Is that something commonly done for baby with jaundice?
It's not commonly done. Okay, so if you institute the phototherapy treatment early, a lot of times, and we identify babies at very high risk, and you institute phototherapy treatment early, a lot of times you can get away from doing exchange transfusion. Okay, but if the bilirubin levels are very high and still doesn't come down, especially if the cause is due to blood group or resource incompatibility very high, exceeding the exchange transfusion levels, they have no choice but to perform exchange transfusion to prevent complications.
Yeah, thank you. Okay, so if let's say the baby has very severe jaundice, but the parents did not seek adequate or appropriate treatment, so what can happen? Is there any complications that can happen?
Yeah. Yes. Okay. Yes. Obviously, there are complications that we do not want to see. Hopefully, right? In fact, and as a doctor, we saw, if possible, we want to make sure that the baby don't up exchange transfusion also. Sometimes because exchange transfusion also not without complication, and if the child need exchange transfusion also, it already means that the bilirubin is quite high, right? So there's some complication of very high bilirubin, right? This bilirubin, as mentioned before in my first slide, is now this unconjugated bilirubin. This can cross the blood-brain barrier, right? So so it basically it get into the brain, and it will stick to a certain part of the brain, and it can cause problem acutely, meaning that immediately, also in long term. So what can happen in the early period is, if the bilirubin is very high, then the baby will become very sleepy, lethargic, not tired lah. Okay, they have very high pitch cry, not able to feeding well, the abnormal posturing, and they become sometimes very low tone. We call hypotonia. Hypotonia means it feel lembek lah. If you touch the baby, it's very lembek, and then as condition progress, they can even become, they can have retraction of the neck and the trunk. Okay, abnormal posturing lah. Okay, sometimes they can become stiff. Some can even fit as well, right? And very inconsolable cry, maybe at the end stage it can be not crying at all, maybe comatose. So that is an acute one. We're talking about acute complication. This is called another word is acute bilirubin encephalopathy. This is a medical word. Or they can have a chronic bilirubin encephalopathy, and actually the term kernicterus have been used as a general to indicate all this early kernicterus and late kernicterus and so on lah. So what can cause in the chronic term is some brain damage, or we call it kernicterus, right? And they can present this as something called cerebral palsy. But I'm sure some of you may be aware of condition called cerebral palsy, where a child cannot walk properly, cannot talk properly, the learning difficulties and so on, right? So in high SB, they can cause something called chorioathetoid cerebral palsy, right? Kind of type of cerebral palsy. If not that severe, also sometimes they can have just hearing loss or high frequency hearing loss. All right. So later on, they can present with speech delay, problem with studies, and so on. And of course, death is a complication, can occur very acutely, all right, if the serum bilirubin is very, very high. Maybe you wonder what is very high. Okay, again, it depends on the condition of the child, because whether this child is premature baby, term baby, what is the weight, any other risk factor. If baby have, for example, is born with not enough oxygen or have sepsis, and these are all risk factor, or acidosis. I mean, the body is a bit acidic during that time. These are all will determine the level which is danger to the brain. But generally speaking, we will take 20 is actually quite high. I'm not saying 20 will cause brain damage. No, nobody knows what level. For example, this NICE guideline in UK, National Institute for Clinical Excellence, something that they take 25 and above is high, right? So generally anything below 20 is okay. 20 to 25 you have to be careful, because in our place here 22 we do ET also, 20 also maybe do ET, depend on the risk factor. All right, 25 usually end up ET lah. All right, usually I mean it depends on the condition still. All right, if you treat with phototherapy it comes down, then probably you may not need to do, all right, as an exchange transfusion. So if possible we should try to avoid if not necessary. Okay, but if necessary to do exchange transfusion, it have to be done, all right, because sometimes the doctors come and ask the mother, we need to do exchange transfusion for your baby because the bilirubin is very high, can you give consent or not? Why you need consent, or when we ask for consent sometimes they become scared. Of course we need to consent because this is not without risk lah. I mean, every blood transfusion have a risk, a procedure have a risk, all right, we don't need to talk about that. Okay, it's too long, but we need a consent as well. But when take this, parents sometimes scared, so you have to trust the doctor. What we are trying to do is the best for the child. When we say we want to do exchange transfusion also, it's not an easy process, we have to sit down there 2-3 hours slowly exchange the blood. It's not easy, and I don't think doctors enjoy doing this, all right. It's not a good a very pleasant experience, all right. But for the sake of the child, if we need to do, we have to do, because without doing that, sometimes the bilirubin will just go high and high, and the brain damage will be irreversible. So okay, so that thing, if you are not sure, then you can always ask the doctor to explain to you lah, right? So the moral of the story here, we must take a high serum bilirubin seriously, and be admitted if needed to, all right, and don't take it lightly, especially if it's high. Okay, the reason we're telling you this complication is not to scare people. No, this is reality. We have to tell you, there are everything in life, there's a good and bad thing about that, isn't it? So that we know that these are the bad possible thing that can happen, so we try to avoid it by proper knowledge and the action we take according to that.
Yeah.
So, but generally
nowadays,
speaking, but good thing about this, we don't see much of this connectors, baby, all this lah. Yeah, very, very, very rare. Okay, the incidents are very low. Thank God, because our health system have improved. There are a lot of phototherapy available, early intervention for exchange transfusion, and the mothers out there also very smart already now. They know, okay, have to bring to hospital.
Yeah. Nowadays, actually, we hardly do any exchange transfusion, and we hardly see any cases with, severe complication of high jaundice.
Yeah, that's good.
Right. Yeah, good to hear that. All right. So we learned from the earlier slides that jaundice, actually, most of them resolve within 7 to 10 days, but there are actually some babies who can have jaundice for a longer period of time. So can you tell us what is the cause for that and what can be done for that?
Okay. Thank you. So this is all right. As mentioned before, if a physiological jaundice, usually they resolve by 10 to 14 days, is clinically no more visible jaundice. Of course, if you take the blood test, maybe there's still bilirubin of 2, 3, finally will go off. But visibly, they are not more jaundice anymore, right? So if the baby become jaundice more than 14 days in a term baby means more 37 weeks of gestation and above, all right? And preterm baby below that, right? So in preterm is more than 21 days. So this is what we call prolonged jaundice, right? Prolonged jaundice here is need a different approach because here we are not talking about physiological jaundice anymore, right? So in prolonged jaundice, we need to rule out why is it important you seek medical attention as well. This one your mothers must know in case you are somehow left out of the follow-up or you forget to go for follow-up. You need to know that if the jaundice still after 14 days, you must see doctor and the doctor will try to find out what is the problem. So basically, we want to rule out a few important causes. The number one is urinary tract infection. All right, sometimes maybe with urinary tract, at least we want to rule out a possible treatable cause first, right? There are many causes of prolonged jaundice, but very important we rule out treatable cause first, like urinary tract infection. Baby can have infection in the urine, which somehow cause jaundice as well. Another is a thyroid hormone deficiency, which is also treatable. all right, and this is called hypothyroidism. Luckily, we already screened the baby when they are born with cord blood TSH, call it thyroid stimulating hormone, taken at birth. And if that is abnormal, the nurse will call you back. All right, but sometimes patient maybe not come for follow up or what, or sometimes some certain thyroid hormone deficiency cannot be detected. All right, so in that case, they can present with prolonged jaundice. In fact, prolonged thyroid hormone deficiency is one of the important cause of prolonged jaundice. Okay, in our place here. So why is it important to detect thyroid hormone deficiency? You see, if the baby is deficient in thyroid hormone, studies have proven that, okay, I mean, if you detect them at thyroid hormone deficiency in the newborn and you detect early and you treat them, treatment is very simple. Just take a thyroxine hormone tablet, thyroxine tablet, which is just like simple tablet, only no side effect, all right? And it can prevent any other complication. But studies have shown if you delay in starting this hormone treatment, as early as 28 days or 1 month, it has a long-term significant neurodevelopmental outcome, meaning that it may affect the child's potential intelligence and so on. The child may not become cacat unless it's really not treated, but it can affect. So it's very important that because thyroid hormone is important for the growth of the brain, all right? So we need to detect this as well. And of course, one of the most important causes is something we call biliary atresia. This is where the child is born with the biliary tract, means the empudu lah, the biliary, the gallbladder, the tube coming out from the gallbladder just below the liver there. All right, this is called biliary tract. All right, so biliary atresia is a blockage around the draining of that bile. All right, so they are born with this, and this slowly progressively get worse after birth. All right, so how they present? One of the things they can present is prolonged jaundice, and they also may have pale stool, like this. You can see in this color here, pale stool on the right side. There's a pale. There's a normal, not a normal stool, right? Stool or poop lah, berak. So the normal color, if you see on the left side of the slide, this is a healthy stool color. This is something called stool chart, all right? And down here, these are the stool which is pale, all right? In fact, if I'm not mistaken, in Japan or Korea, they have done some studies by giving this stool chart to the mother and to tell them to come back. If you see your stool is suspected stool like this, they really pick up a significant degree of biliary atresia early. All right. So, mother, please be aware, the stool like this is not normal. Okay. Apart from the pale stool, they also can have a tea-colored or dark urine because of the bilirubin. Okay. In biliary atresia, the bilirubin is a bit different type that is increased. It's called conjugated bilirubin, which is a water soluble, and it gets into the urine. And because the bile do not come into the intestine, which bile contain the bile pigment which give the color, brown color to the stool, that is why the stool become pale. So biliary atresia is very important that you need to rule out. Why is it so? All right, because if there is a biliary atresia, you need to treat it preferably by 60 days lah. All right, at most is 90, but 90 too late already maybe. All right, by 60 days, so that the outcome or the prognosis will be better. If not, what will happen? Say they are detected late, you may still go for treatment, something we call Kasai procedure, a surgical procedure, but the damage will be done to the liver already, and the liver will slowly fail, and then they may end up liver transplantation. In fact, biliary atresia is one of the common important cause of liver transplantation worldwide. Okay, for children lah. So biliary atresia we need to rule out. Okay, so pale stool mainly this is we want to rule out biliary atresia also. All right. Sometimes it is not biliary atresia. Sometimes it can be something we call neonatal hepatitis syndrome or neonatal cholestasis, because there are some other metabolic problem, some enzyme problem, or can also cause this kind of presentation. But that is a doctor's job to rule out. Once the okay, so now after doctor have ruled out all these important condition, okay, then say for example prolonged jaundice, okay, we check the SPE. The doctor will do some blood test, some urine test, and make sure this is not, number one, it's not conjugated hyperbilirubinemia. Conjugated, you must rule out biliary atresia. The doctors or the nurses the nurses listening should be knowing this as well, right? Conjugated hyperbilirubinemia is never ever normal. Okay, let me share you some interesting thing. People have doing some studies in certain country. A newborn who is born on the first 3 days of life, they check the conjugated bilirubin level, and they follow up these people. All right, this child, and then from the child who are being followed up, they will notice to be a biliary atresia. When they look back at birth, actually the conjugated bilirubin already increased slightly. So that's how it is important for people, even doctors and nurses. Conjugated bilirubin cannot take it lightly. All right. So after we excluded this thing, important thing, then but they are otherwise well. And this jaundice is not conjugated, it's unconjugated hyperbilirubinemia. So the child is otherwise well, thriving well, weight gaining well, all right? No other problem. The jaundice is there, but slowly coming down. So then we think about something called breast milk jaundice. Okay. Again, are we trying to blame the breastfeeding and breast milk? No, we are not. Okay, but this is the fact of life. All right. So as Dr. Chan has said before, you still need to continue breastfeeding. Don't worry, so-called breastfeeding jaundice. You optimize your breastfeeding, all right? Because breastfeeding is the best, and breast milk is also you still continue as well. Why? Why is it breast milk cause jaundice? In fact, if you compare breastfeeding child and bottle feeding child, yes, studies have shown breastfeeding child have more prone to have jaundice and slightly higher as well. But that doesn't mean that you shouldn't breastfeed. You still need to breastfeed. Breastfeed. If the breastfeeding not enough, what you do? We just supplement with express breast milk or formula milk if really needed for short time. Okay, so breast milk. The theory about breast milk is there's something called a beta glucuronidase. This is one theory, but there may be other reason for it. It causes the increase in the bilirubin to be absorbed from the gut to the blood. That is why they become jaundice. So this is why breast milk jaundice. So what should we do if they are breast milk jaundice then? Okay, some people said some suggestion that you can actually stop the breastfeeding temporarily for 2-3 days, and then when you resume it, it will not go up. All right. But some also recommended it's okay if it's not high, just continue. And most of this breast milk jaundice will slowly resolve by 12 weeks around 3 months. Okay. So, but important here mentioned here is breast milk jaundice is a diagnosis of exclusion. All right. So it is not the what we call bukan duty or hak the parent untuk decide this is breast milk jaundice. If you see your baby is jaundice after 14 days, in fact, some places they give leeway up to 3 weeks because if the child is okay. But in Malaysia we take 2 weeks. All right. So after 2 weeks still jaundice, you have to see doctor and rule out the treatable harmful causes, or maybe not harmful but important cause you need to rule out. Then it is breast milk jaundice. You can continue to follow up until the jaundice resolve. Right? Don't just say you suddenly default follow up, but the jaundice not resolved. It can be something else. Okay. Yeah, I think this for the time being. Thank you.
Thank you to both speakers. I think that ends our talk for now. Thank you again to both speakers for your comprehensive and interesting talk. We will begin our Q&A sessions now. I have some questions from the Facebook. First question is from Madam Nairobi. Is it true that jaundice related to mother's eating habit during pregnancy? Usually the elders will advise the pregnant mothers to drink water and avoid drinking coffee to avoid jaundice in babies. What's your advice on that?
Yeah, okay. I don't think so, because I mean there's no evidence, right, to this. In our community, of course, there are a lot of people like to tie things to eating habit, eating this, eating that, eating cold food, hot food, and so on. I think that's not the reason, right? Not hitting. Of course, there are some diseases which can be related to what you take in some, especially medication you take. But here, as we mentioned just now, the jaundice here is basically because of breakdown of the red blood cell. It's nothing to do with eating habit now. Unless yeah, that's it.
Yeah, and also factors for jaundice as well. There's no mention talking about mothers' eating habits during pregnancy. Okay, so I think generally the elders advise, because they just want pregnant mothers to eat healthily during pregnancy, and should also avoid coffee caffeine, too much caffeine. This have caffeine can have adverse effect to the baby causing low birth weight, even so on. Okay, so actually, if you want to say it like that, it's indirectly, too much caffeine will lead to small baby, low birth weight, and therefore it is also a small risk factor for neonatal jaundice. Generally, it's not related to the eating habits.
All right. There's another questions from Madam Monica regarding eating habits as well. But this is about during confinement. Is it true that if mother take any herbs or medication during confinement, that will lead to jaundice in babies?
So to quote from our Malaysian clinical practice guidelines on the management of neonatal jaundice, it says that there is no good quality evidence to suggest that maternal consumption of traditional herbs during confinement is a risk factor for neonatal jaundice. Okay, so no good quality evidence. Okay, but the problem with herbal medication or herbal remedies is that sometimes we don't know the content of it, and sometimes the ingredients, there may be some ingredients that are not declared, and we're also not sure about the preparation of these herbal remedies. Sometimes they may be contaminated with heavy metals, and all that can be dangerous to the baby. So actually, if you're very worried or baby is unwell at that time, having very high jaundice, then it's best to avoid herbal medication okay. So, but of course, if your baby is well, jaundice result, you really need to take some herbs, then should be fine. Go ahead. Yeah.
Because we also know some antibiotic can cause worsening of the jaundice, like ceftriaxone and so on, so cefotaxime or what. So we don't know, as Dr. Tan say, what is inside there, some antibiotics or what, which whether can cause. We don't know, you see. But probably generally people have been taking one, maybe quite okay.
Okay, thank you. The next question is, some parents believe that early morning sunlight have been shown to break down the bilirubin more effectively as compared to the phototherapy light in the hospital. So how do we advise them on that? This is a question from our colleague, Dr. Malvin.
Oh, all right. Okay. Surprise. How are you, Malvin? All right. Okay. So yeah, sunlight. Okay, sunlight contains a spectrum of all the spectrum of light, including that's why you see the rainbow and blue, ultraviolet, and so on, right? So as we mentioned, the phototherapy is blue light, 400 to 490 nanometer. Sunlight is harmful because it contains ultraviolet light less than 400 nanometer, right? So even though sunlight may contain the blue light spectrum, which can bring down the bilirubin level, but it is also potentially harmful because of the ultraviolet light. So we don't know the long-term effect of prolonged exposure of this ultraviolet have been noted to cause some skin cancer, melanoma, and so on. So that's one reason. So the second thing is, so when put under sunlight, okay, also the risk of dehydration as well. All this can also aggravate the jaundice. All right. So this is not generally recommended now anymore. I remember when I was a medical officer in many 20 plus years ago, in some clinic the nurses advise you can put in the sunlight. Okay. So it is not recommended to do that. And I also have read through that in some places in this world they have this something called filtered sunlight. right? They have some filter to use, and that's filter the sunlight, filter the ultraviolet light, okay, and the remaining light can be used for so-called phototherapy, and this is been done. Okay, and maybe that kind of thing is acceptable lah, but not the direct sunlight shouldn't be, because of the one is of dehydration, potential harmful ultraviolet light. But as I mentioned, the filtered sunlight have been used somewhere in world lah. Maybe in a place where the resource limited lah, no, in a resource limited setting, poor countries, they may want to do that.
Okay, this is also the question from also the similar questions asked by Madam Noh Farida. We hope we answer your questions. She's also concerned about whether sunlight is as effective as phototherapy. All right, we hope we answer your questions, Madam Noh Farida. The next question is about G6PD deficiency. Right, this is from Madam Anis. Does baby diagnosed with G6PD, her baby was diagnosed with G6PD intermediate. Does the baby need to be admitted for 5 days for phototherapy as well? Because her baby was actually admitted for only 2 days. The baby was discharged on day 2 of life, and at day 3 of life, she became jaundice and was readmitted for phototherapy. Can you enlighten us on this G6PD policy?
Okay, so the newborn screening, the national newborn screening that we have here is just a qualitative test lah. It says whether yes or no, whether you are deficient or not. It's not a quantitative test, so it doesn't tell us the value of the deficiency. Okay, so that's why your result may turn out as like intermediate. So ideally, if you get this kind of result, we should send for a quantitative test to evaluate the level, the value, how much is the deficiency lah. So if the deficiency is significant, then for up to 5 days and monitor. Okay, so your baby was discharged on day 2. So because you know that your baby has G6PD, so-called intermediate, so probably you are also aware you need to be more aware about a baby can get higher jaundice. So you need to follow up the next day or do a daily check to make sure the serum bilirubin doesn't go up too high lah. Okay. So yeah.
Yeah, so it's actually important to get a quantitative check on the G6PD enzyme level, because the screening only tells us the quantitative. All right.
Yes or no?
Yeah, yes or no only. All right. Okay.
Maybe,
sorry. I think I missed out the two. Yeah, the quantitative is important. The screening only tells us the qualitative. All right.
Maybe
yeah.
I can add on a little bit. I think our madam, she's tried to ask why was she went back at day 2 after 2 days, isn't it?
Yeah.
Usually we keep them 4 to 5 days, right? But there might be a reason that that particular child went back early, probably whether it's a request from the parent or whether it can be monitored at home and then come back. But whatever it is, you go back, then they have to come back and check daily SB check, or if really the child looks yellow. So I don't think that any doctor will discharge them if the child is really jaundice. Probably there was not jaundice or the level was very low. All right. Sometimes we keep them in the, but usually we keep them in the ward 4 to 5 days. All right. So even if you in the ward, sometimes say the bilirubin is not high, not needing phototherapy, we do not recommend to give prophylactic phototherapy. Just put them on photo to hoping that the bilirubin doesn't go up. This is not recommended, right? You have, because phototherapy also have the side effect and so on. So, for example, the child say SB is 6, for example, day 3, for example. So it doesn't need photo. So maybe for that time, whatever the reason, we don't know. Maybe the ward is too full or some other issues or what. So maybe you go back, but you can come back, must check the bilirubin the next day. Right? I think this could be my guess lah. So you cannot go back and you don't check the bilirubin, cannot. But as a general rule, we do not discharge them early lah.
Right.
Usually 4 days, 5 days. I think now at least 4 days. I think that answered the question.
Madam Farida wants to know what are the harmful effects of G6PD deficiency?
This harmful lah, not harmful. Is you're deficient in the enzyme, so your red blood cells tend to rupture more easily, trying to break down more easily. So it we need to be very careful about this in the newborn period. So we need to watch out for, because deficiency, they can get severe jaundice because of their G6PD deficiency. This is only during the neonatal period. Okay, so because a genetic condition, yes, it's a lifelong condition, but most of the time, throughout their life, they will have no problems. So having this condition is actually not harmful to them. Okay, so the main thing is they need to know what it is about and to avoid the triggers that could trigger the red blood cells to break down, and also to know what signs when they develop. Okay, when the red blood cells break down, basically they can have jaundice, a dark color, what we call Coca-Cola colored urine. Okay, they can be very tired. And when they have these symptoms, then they need to immediately seek treatment, because these are signs that the red blood cells have breakdown. So you need to seek treatment immediately lah. Okay, so but most of the time they go out throughout life without any problems. Okay, so you just need to know when you need to seek treatment. When you get sudden onset of jaundice or look pale, having dark urine, then you need to go through your treatment immediately.
The next question is from Madam Geraldine. She wants to know whether we can add any traditional herbs or anything that can be added into the baby's bath to reduce the jaundice.
Okay, so there's no evidence to say that all these herbs can actually reduce jaundice. Sometimes our elders tell us, oh, it actually works, but actually the jaundice resolve actually because it's the natural history that the jaundice is anyway, according to the physiological jaundice, according to the normal physiology, it's going to resolve anyway. So sometimes they thought that it actually works. Okay, so but there's no evidence to show that this works lah. And at the same time, as I spoke about earlier regarding these herbal remedies, so we're not sure the content, and it can be preparation may be contaminated. So this content may be absorbed in the baby's skin, and don't know, maybe may affect the bilirubin metabolism. So it's best avoided, especially your baby have severe jaundice. Okay.
Can I add on to that? So sometimes parents are worried to want to add on this and that. All right. But the important thing here is, especially you're talking about the physiological jaundice here, right? Or breastfeeding jaundice. We want to make sure the child have adequate amount of milk. This is number one, very important thing. Okay. Why? Because if not enough milk taken, then they'll be dehydrated. Right? The body dehydrated means not enough water in the body, right? Breast milk have nutrient and the water lah kan. So they'll be dehydrated, so the bilirubin will go up, right? Second thing, by taking a lot of milk, breastfeeding, the milk is their food, you see, so they also will pass motion. All right, the more they take, the more they pass motion. In fact, by passing a lot of motion, a normal baby will pass around 2-3 times a day. Okay, as long as it's not diarrhea, the more it is better lah. So when they pass motion also, it will clear off the bilirubin. This is called, and it reduces something we call enterohepatic circulation, because if the bile is there, in the stool is there, so the bilirubin will keep on be reabsorbed into the body, and it increases the jaundice. So in fact, those baby who do have delay passing the stool, or not passing stool so much, or have in fact intestinal obstruction and so on, they are like condition called pyloric stenosis, and so they become jaundice, you know. All right, so passing stool is important also for the baby. So that is more important. Sometimes I also last time di klinik pun ada orang cakap, can we give water instead of the milk? All right, so that's not good. All right, because it doesn't contain any calorie and so on. Okay, so you have to just supplement with milk lah. Okay, so I don't think need to add anything. All right, because as Dr. Tan say, we don't know what is it. Okay, and it's not proven.
All right. Is jaundice fatal if not treated?
Yes, this jaundice fatal, is it?
Yes.
It depends on what you are talking, what you are asking about. Okay, as if it's a physiological jaundice, as we mentioned, right, it will go up, right, within day 3, day 5, or in East Asian population, day 7, it will plateau, right? Plateau mean come to a level, steady level. All right, that one usually say around 10 to 12, at most maybe 15 if you're talking about exaggerated physiological jaundice. This is usually is harmless lah. If you're talking about normal baby, all right, the level of 15 what is not cause any problem. Okay, all right. But if you're talking about the bilirubin is so most of the time probably if you don't do anything, okay, the bilirubin will just go up and come down. Okay, but why we need to treat them with phototherapy or not? Because we don't know what we are dealing with. There's no way that you can prove 100% this is physiological jaundice and so on. We don't know which baby have which condition. All right, so that's why in fact phototherapy, there's a recommendation to start phototherapy at certain level. Okay, so our level here is actually quite lower threshold if you compare to this some so-called NICE guideline and so on. All right, some start phototherapy at 18 or 17. Okay, so to be safe, we just start low. All right, so if you say fatal, not necessarily. It depends on the case you are talking about. So if physiological jaundice, definitely not fatal at all lah. It will go up and will come down. Okay, if you talk about long-term effect, usually happen only if the bilirubin is very high, say maybe 20 plus, 25, and so on. Okay, there's no. But if you're talking about somebody with complication, premature baby, okay, baby with sepsis, or and then we have discussed this ABO, hemolysis, ABO, GCSPD. The jaundice can go high and causes the damage, and yes, it can cause death. If it's really not fatal, if very high SB level. If not, then the child may end up kernicterus or hearing loss and so on. Okay, so if that is the answer lah. So if it's a physiological jaundice, it may come down. You may just escape without phototherapy lah. It's okay, but you don't know where is it going to go high. We don't know. The problem is sometimes why patient come to the hospital with very high SB. Sometimes because they delay seeking treatment, they think this is not normal jaundice, it will come down. Okay, say for example, they go to the clinic today, its SB is 14. Wait for tomorrow lah, I cannot go today. Right, maybe it will come tomorrow. Go and check 18 or 19. So suddenly admit, it continue to go up, and that is a problem. Okay, so if the doctor say admit, try to be follow the advice lah. If not, at least you must check every day. Okay, see the trend. Okay, so the moral is you have to follow the medical advice. Okay.
This question is about prolonged jaundice. So as we are aware of, some babies can be having jaundice for a longer period of time, up to 2-3 months. So the parents will need to bring their children for bilirubin check for up to a period of 3 months if they have prolonged jaundice. This Madam Anis is concerned, how often do we need to monitor their SB if we already rule out the 3 causes mentioned by Prof just now during the prolonged jaundice slide? And until when should we monitor the jaundice?
Okay, all right. So when you say prolonged jaundice, when we bring the child for follow up with the doctor in the clinic, all right? Not only they do the serum bilirubin check, all right? The first one of the most important thing that the doctor do is something we call liver function test. Right, this is one of the important tests must be done. Okay, in this liver function test, they also look at the total bilirubin and conjugated bilirubin. Okay, I'm sorry, I have to be a little bit technical so that you understand this. So this conjugated bilirubin is, as I mentioned before, will indicate diseases of the biliary tract obstruction or liver disease, metabolic disease, and so on. All right. So first, the doctors, first and foremost, the doctor have to rule out whether this is conjugated or not. All right. If it's conjugated, then the doctor have to do for some other investigation, they will refer you usually for you have ultrasound scan of the biliary tract, and based on that you may need another test called HIDA scan to see really there's an obstruction of the bile duct and so on. Okay, so then okay, say you already rule out all this. The madam asking question. Okay, you rule out all this already. So if rule out still, usually the doctor will follow up in the clinic. Okay, with serial LFT monitoring. Right? They may want to do a repeat liver function test every 2 weeks to 1 month to make sure that the bilirubin still remains unconjugated. It's not conjugated. Okay, the liver enzymes are okay. The liver function is okay. They measure something called serum albumin, liver enzyme to make sure the liver function is all right. Okay, so it's not just a follow-up of the bilirubin. They usually follow up with liver function test, and then make sure it resolve lah. Okay, apart from this, they may do other tests like something we call torture screening to see any congenital infection. Some many small tests lah. Metabolic screening, IEM screening, and so on to just make sure there's nothing. Say, of course, suppose they already rule out, then this is just breast milk jaundice. As I mentioned before, usually it can last up to 3 months. All right, but this have to be excluded by confirming, doing another liver function test at the end of it to make sure that everything have normalized. Right. So that's one thing. To answer your question now, how long? Okay, as long as the baby is visibly jaundice, you need to follow up still. Right. Some of these prolonged jaundice baby, they already rule out biliary atresia, urinary tract infection, metabolic screening, all normal. All right, but they're still jaundice and they still have some degree of conjugated bilirubin or liver function may be deranged. We need to follow up until normal. That meaning that some of the baby are just something we call neonatal hepatitis syndrome, but we did not able to find the real cause behind it. Or it could be some infection which we did not detect and it just resolved by itself. So we must follow up until we think it's normal. The function is normal before we can discharge. All right. So it is a duty of the doctor to make sure it is okay lah. So, but if you're concerned about breast milk jaundice, easily around 3 months is already the liver function all should be okay. It's just conjugated, and the jaundice should resolve. Resolve here means the bilirubin should be less than 1 milligram lah. That's the normal lah. Okay, right. So it should resolve.
Okay, I think some audience are interested to know about this home phototherapy. Can you share some knowledge on this with us?
Me or okay?
Any speakers will do.
Okay lah, home phototherapy. Yeah, there are some places that they may provide you with home phototherapy, right? I can't say yes or no 100%. It depends on the condition lah, right? Basically, if the child have no risk factor, okay, and can be monitored well at home in terms of the serum bilirubin. Of course, you have to go to the clinic or somebody come to your hospital, to house and check. Also, the general well-being of the child, right? Then maybe you can, and you think you can take care of the child, then it probably is okay lah. Okay, but it's not easy also. Now, sometimes the baby sleeping there and the mother also sleep middle of the night. What happens if the spectacle, the cover of the eye get loose and so on, because prolonged exposure to the light can also damage the eye. Whereas in the hospital, maybe the nurse is always there looking around and so on. But of course, if it can be looked after, then home therapy. I don't know whether it's really 100%. It's not really to be recommended unless you are really sure you can take care, or the one who offering you can provide a proper guideline and to how you should continue this and care to be taken lah. And definitely it's not if somebody have risk lah, this is PD lah and so on. I don't think that should be done lah. But for the sake of convenience, sometimes if it's really you can monitor at home properly, then maybe it's okay. And I know there are some centers who provide this home therapy, but if it's properly, then maybe all right. But if you cannot monitor properly, then it's better to be at house, at home, at hospital. I myself have experience. It's not easy to monitor at home. I don't know whether Sim you had this experience or not.
Yeah, I also do not do home phototherapy. I prefer to be, doing phototherapy in hospital. Because there are definitely more support than at home. The next question is about follow-up of babies with jaundice. Do we need to follow up the baby until the serum bilirubin falls below 5 milligram per deciliter?
Yeah, as I think Prof. Amin has elaborated regarding the prolonged jaundice, yeah, once we have ruled out all the treatable or dangerous causes, and most likely the diagnosis is a breast milk jaundice, then yes, usually we'll follow up and monitor the bilirubin and less than 5 milligram per deciliter. So it doesn't need to be done frequently. If you're very sure it's a breast milk jaundice, so sometimes we can see in 2 weeks' time to repeat, or 3 weeks' time, until it really come down to less than 5 milligram per deciliter lah. But you don't need to do so frequently anymore once you know it's just a breast milk jaundice.
Usually we see the trend is coming down. It's usually reassuring lah. If clinically the trend is coming down, clinically no jaundice, especially mild jaundice they can detect at the face and so on in the eye. So if clinically is okay already, the child is gaining weight, the stool is not pale, all right, and then the bilirubin coming down, yes, then they will discharge.
All right. Let me check whether there's any more questions coming in.
I think no more.
So far, I don't get any more questions. Maybe I just ask a question now. How about the practice of giving baby goat's milk instead of cow's milk formula? Does that help to really reduce the jaundice?
No lah, no. Goat's milk is not recommended for babies under 12 months old. Is not recommended. And in the first place, also why we are giving cow's milk, right? Okay, so breast milk is still the best. So simply said, human milk is meant for human babies. So goat's milk should be for baby goats lah, not for our babies. Okay, because unmodified goat's milk, they do not contain the right amount of nutrients. So this may cause electrolyte imbalances in our baby, cause the baby's blood to be acidotic, and then burden the kidneys as well. Okay, and then they also, because they don't have the right amount of nutrients that our baby needs for growth, they can cause nutrient deficiency in our baby also, such as folate and iron deficiency. And if you give the fresh unpasteurized goat's milk, it also may be contaminated. So this carries the risk of additional risk of infection to the baby. And also, like cow's milk, goat's milk can also cause allergies, and some allergies can be life-threatening. So it's definitely not recommended, goat's milk, and it doesn't help with the jaundice.
Right, I do not get any more questions. So I think if there's no other questions from the audience, we will conclude our session now. All right.
Okay, so some of the take-home message is from our talk this past 1 hour plus is that jaundice is common, and most of the time is physiological. Okay, so but anything within the first 24 hours of life is always abnormal. Jaundice within the first 24-hour life is abnormal. Okay, so if baby is unwell early, okay, so brain damage, yes, is a complication that may occur if severe neonatal jaundice, but this is very rare, okay, and highly preventable. Okay, phototherapy is the mainstay treatment, okay, for neonatal jaundice, not sunlight. Okay, breastfeeding is beneficial. There's so many benefits of breastfeeding and should always be continued, regardless of whether baby has jaundice or not. And jaundice beyond 2 weeks of life will require further investigation.
All right, I think we have come to the end of this health talk. Thank you once again to the organizing committee and to our two experienced speakers for their excellent and also informative talk. Last but not least, to all the participants who have joined us here today, thank you and have a nice day. See you next time.
Goodbye, Dr. Sim.
Thank you.
Bye.
Bye.